Welcome everyone. Myself Ankita Mondal, student of BSc Nursing 5th semester of Jiaganj School and College of Nursing. Today I would like to discuss on a very important topic in childhood nursing, that is neonatal resuscitation. So first let's know what is neonatal resuscitation. Neonatal resuscitation is an intervention after a baby is born to help it breathe and to help its heart beat. Next, we will see what are the purposes of neonatal resuscitation. First, to establish an effective circulation. Next, to establish respiration promptly. To prevent irreversible cerebral anoxic damage. And next, to maintain the core temperature. So there are the four purposes of the neonatal resuscitation. So now we will see what are the indications of neonatal resuscitation. First, we will prepare ourselves for neonatal resuscitation in case of preterm delivery. Next, if there is fetal distress, meconium staining, antepartum hemorrhage, severe IUGR, malpresentations and antenatal diagnosis of fetal abnormality. So we'll see what are the contraindications of the neonatal resuscitation. First, if the baby is born in less than 23rd weeks of gestation. Next, the birth weight of baby is less than 400 gram, or if there are any congenital anomalies, and then diaphragmatic howling. These are the contraindications of the neonatal resuscitation. Now we will move on to what are the articles that we will require to perform the neonatal resuscitation. First, we will need the all sizes of mask. Next, ambu bag, laryngoscope, all sizes plates, sticking tape, feeding tube, suction catheter, umbilical line, cord clamp, injection adrenaline, normal saline, chest leads, vitamin K, suture, cutting blade, cannula, syringes and a central line tray. After that, we will see what are the TABCs of resuscitation. The components of resuscitation procedures as described as the acronym of TABCs of resuscitation. T stands for maintenance of temperature. Next, A for establishment of an open airway, B for initiation of breathing and C for maintenance of circulation. Now let's see what are the procedure or what is the procedure of neonatal resuscitation. First, initial assessment. What we have to initially assess? The needs for resuscitation can be identified by rapid assessment, which follows the three characteristics. First is term gestation, next is breathing or crying, next is a good muscle tone. First, we will see that if the baby is born in the gestational or the baby's gestational period is between 35 to 42 weeks or not. If baby's gestational age is for 35 to 42 weeks, then it's okay. Next, we will see what is crying or breathing. If the baby cries after birth, then there is no need of resuscitation. Next, we will see that if the baby is having a good muscle tone, generally we know that a baby's body or baby's limbs is flaccid after birth. So we will see that if the baby is having a good muscle tone. If the answers to all these three questions, that is term gestation, crying or breathing and good muscle tone is yes, then there is no need of resuscitation and we will proceed towards the immediate or essential newborn care till the rooming in. If answer to at least any of these three questions is no, then we will require the following steps of resuscitation, that is first initial steps of resuscitation or ventilation or good compression or endotracheal intubation. So after we know that after the baby is born, the first 60 seconds is known as the golden minute. So within the golden minute, we have to perform the initial steps of resuscitation. We have to re-evaluate the baby and we have to begin the ventilation if needed. So first, let us see what are the initial steps of resuscitation. First, we have to provide warmth. How we can provide warmth? We can provide warmth by receiving the baby in a preheated towel or placing the baby in a radiant warmer. If the warmer is not available, room heater or a bulb of 200 watt can be used. Next, we have to provide the baby in the sniffing position. Next, we have to maintain the sniffing position. The baby should be positioned on the back, slightly extending the neck in sniffing position. How this can be achieved? This can be achieved by placing a small roll towel under the shoulder. This position brings the posterior pharynx, larynx and trachea in line, which ensures unrestricted airway. After maintaining the sniffing position, we have to maintain clear airway. How we can maintain the clear airway? We have to do suctioning. First, suctioning of the mouth should be done and then the nose. That is, oral suctioning should be followed by the nasal suctioning. In case of oral suctioning, we have to insert the suction tube 5 cm, and in case of nasal suctioning, we have to insert the suctioning tube 2 cm. And the pressure should be 100 cm of water. Suctioning should be done carefully to prevent the stimulation of posterior pharynx, which can lead to bradycardia and apnea. Next, after maintaining the clear airway, we should dry the whole body. The baby's whole body should be dry and immediately the wet linen should be removed. The baby or the neonate is then placed further on a pre-warm towel to reduce the heat loss. Next, after drying the whole body of the baby, we have to provide tactile stimulation. Providing tactile stimulation by slapping or flicking the soles of the feet or rubbing the infant's back once or twice to stimulate breathing. We have to flick the soles of the baby, or what we can just do is rubbing the back of the baby once or twice. Continued use of tactile stimulation may be harmful and wastage of valuable time. After providing the good tactile stimulation, we will see that the baby who was not spontaneously breathing may breathe after providing 1 or 2 tactile stimulation. Next, after providing the tactile stimulation, we will re-evaluate the baby. How we can re-evaluate the baby? We will re-evaluate the baby by checking the heart rate and respiratory rate. How we can check the heart rate? We will check the heart rate simply by auscultating the heart rate for 6 seconds and then multiply it by 10. Next, we will check for the respiration. In respiration, we will see that if there is good chest rise, or if the patient is having any labored, or if the baby is having any labored breathing or not. Now we will provide the supplemental oxygen, or we will see if the baby requires supplemental oxygen or not. Infants who have already sustained a heart rate of more than 100 beats per minute and adequate respiratory effort but remain cyanotic may require supplemental oxygen. We will check for SpO2. We know that the SpO2 of right hand is equal to the SpO2 of blood delivered to the brain. We will see what is the targeted preductal SpO2 after birth. Within 1 minute of birth, the SpO2 rate should be 60 to 65%. So after checking the SpO2 within the golden minute, if we found that the baby's SpO2 is 60 to 65%, there is no need of providing oxygen, because that is the normal SpO2 level of a neonate within 1 minute. So same as that, within 2 minutes, the normal SpO2 is 65 to 70%. Within 3 minutes, it is 70 to 75%. Within 4 minutes, it is 75 to 80%. Within 5 minutes, it is 80 to 85%. And within 10 minutes, it is 85 to 95%. The initial steps of resuscitation, if we see that the heart rate is below 100 and there is gasping or apnea, there is no gasping or apnea, but labored breathing or persistent sinuses is present, then what we can do, we will clear the airway, we will monitor the SpO2 and consider the CPAP. Then if the heart rate is below 100 and there is gasping or apnea present, then we will start the positive pressure ventilation by also monitoring the SpO2 levels. Next we will see what is the positive pressure ventilation. Positive pressure ventilation is the most important aspect of newborn resuscitation, in which we can ensure adequate ventilation to the lungs and oxygenation to vital organs. Now we will provide the positive pressure ventilation to the newborn. We will provide the positive pressure ventilation. We will require the umbu bag or the bag mask ventilation. We will stand at the head end of the baby. That is, we will stand at the head end of the baby and we will place the mask by holding it in a C position. Then we will press the umbu bag 1001, 1002, 1003, 1004 and 1005. We will see for the effective chest rise. If we find that there is no effective chest rise, then we can evaluate this is proper or not through 5 or through a mnemonic, that is MR SOPA. M for mask adjustment, R for repositioning, S for suction, O for open mouth, P for increased pressure and A for alternative airway. If we see that the chest rise is not adequate by providing positive pressure ventilation, then we can use the MR SOPA technique, that is we have to adjust the mask. We have to place the mask correctly, that is within the we have to cover the nose and the mouth of the neonate. Next, we have, if the position is not correct, then we have to reposition the mask. Then we have to again provide the 5 cycles by counting 1001, 1002, 1003, 1004 and 1005. Else we will open the mouth, then suction the patient for any secretion, and then we can increase the pressure of the bag mask ventilation, or we can choose any alternative airway. After providing the bag mask ventilation, we will evaluate the neonate after 30 seconds. If we see that the heart rate is more than 100, then we will stop the bag mask ventilation. If we see that the heart rate is less than 100 and is also less than below 60, then we will continue the bag mask ventilation and also start the chest compressions. Now, after providing the positive pressure ventilation, if we see that the heart rate remains below 60 beats per minute, then we will provide the chest compression. We know that we provide the chest compression in the xiphoid process. You see, this is the xiphoid process of the neonate. So we can provide the chest compression using 2 techniques. One is the thumb technique by using the 2 thumbs, and another is the 2 finger technique, that is by using the 2 fingers. In case of thumb technique, we press or we give the chest compression using the 2 thumbs. We encircle the hands in the torso and the fingers. You can see the fingers are supporting the spine. Now, after the fingers are supporting the spine, we provide the chest compression of the baby using the 2 thumbs. We will see 1001, 1002, 1003, and then we will tell our companion to provide the bag mask ventilation. That is, after doing the 3 chest compressions, there will be 1 positive pressure ventilation on 1 airway. So 1001, 1002, 1003, and then we will stand at the head end of the baby. We will catch the umbu bag in a C position and we will provide the ventilation. Next, we will see the 2 finger technique. In case of 2 finger, we will use 2 fingers and then we will place in the xiphoid process. The other hand can be used to support either the baby's back or to take the umbu bag and place it in the baby's mouth to provide the ventilation. This 2 finger technique is usually done when there is 1 resuscitator present. So in 2 finger technique, you will see we will place the 2 thumb in the xiphoid process and we will also place the bag mask ventilation here. Then we will provide 3 chest compression, that is 1001, 1002, 1003, and then we will immediately take the place the umbu bag and then we will provide a ventilation. So this is the two-finger technique. So as I have discussed, there is two techniques to provide chest compression. One is the thumb technique and the other is the two-finger technique. Usually thumb technique is practiced because the two-finger technique is more tiring. On the other hand, the thumb technique is less tiring, and this can be performed very easily. Next, we will see what are the site and depth of compression. As I have said that we will provide the chest compression in the xiphoid process of the baby, and for the depth of compression we will provide at a depth of 1/3 of anterior posterior diameter of the chest. We will see a total of 30 breaths with 90 compressions to be achieved approximately, that is 120 to 120 events per minute should be given. So we will see what are the dangers of chest compression can happen. That is we can see broken ribs, lacerated liver or pneumothorax, etc. After 30 seconds, if the heart rate is still below 60 beats per minute, then we will consider endotracheal intubation. Next, after providing chest compression, we will evaluate after 1 minute. If the heart rate remains still below 60 beats per minute, then we will repeat the dose of adrenaline or consider intubation if not already done, and we will rule out pneumothorax or hypovolemia if we see that if hypovolemia pneumothorax is present or not. In case of hypovolemia, if we find that there is a history of postpartum hemorrhage in the mother, then we can administer the O negative blood in the baby, because we all know that the O negative blood is a universal dose. Next, after providing the chest compression, we have already said that we will consider to do endotracheal intubation or medication administration if the heart rate remains below 60 beats per minute. In case of medication administration, we can administer injection adrenaline, that is at a rate of 0.3 to 0.3 ml per kg via umbilical vein, or we can also use volume expanders at a dose of 10 ml per kg. Next, after providing the medication, our resuscitation procedure completes here. Now we will move towards the post-resuscitation care. In post-resuscitation care, we will see that if only bag and mask ventilation required for less than a minute, then we will shift the baby to the mother, and then we will keep the baby in the observational care. Observational care includes monitoring of heart rate, monitoring for distress, sugars, color, saturation and feeding. Now we have discussed the post-resuscitation care if the bag mask ventilation requires less than a minute. Now if a bag mask ventilation is required more than a minute or chest compressions doesn't work, then we will move towards the endotracheal intubation. What we can do is we can monitor vital signs, monitor sugars, and we can continue to provide NICU care. Next, close monitoring is to be done. Now when we can discontinue the resuscitatory efforts, it is recommended to consider stopping resuscitation in newborn if heart rate remains undetected for 10 minutes after ruling out the presence of presumed etiology of arrest and other complications. So we have seen first initial assessment of the resuscitation, which includes three characteristics, that is term gestation, primer breathing and good muscle tone. Then we have moved through the initial steps of resuscitation. Then we have seen positive pressure ventilation, good chest compression, endotracheal intubation and the medication administration, which includes injection adrenaline and volume expanders. So I hope that you all have understood the procedure of neonatal resuscitation. Thank you everyone.